Hi, I am Ehud Asya and I would like to share with you our experience with the Capsular Anchor, a device designed for management of lens subluxation. This is a case of a patient with malpositioned microspherophakia with advanced cataract. The zonules are sparse, elongated and weakened, but most of them are still intact. Following capsulorhexis and iodide dissection, the lens material is removed by cautious phacoemulsification with minimal manipulations of the unstable capsule. I personally prefer to use anterior chamber maintainer to maintain the constant intraocular pressure and prevent hypotony throughout the operation. Also, vortex aspiration is more delicate in my hands using manual aspiration. The remaining cortical material is then flushed by forced water jet, leaving a clean and nice capsular bag. A capsular tension rig is optional, and it is injected into the bag to maintain the round contour of the capsular equator, not to fixate the capsule to the scleral wall. The needle of the 9-0 Prolene suture is inserted about 2 mm from the limbus and externalized through the main corneal incision using a 27 gauge needle as a guide. The needle is then threaded through the hole at the base of the capsular anchor and then reinserted through the main incision. The 27 gauge needle is now inserted about 2 mm lateral to the insertion point to extract the Prolene suture. Now the capsular anchor is inserted through a 2.5 mm incision and it is positioned using a lens hook. One lateral arm is directed behind the anterior lens capsule through the capsulorhexis. And then the second prong is located and inserted behind the anterior capsule. The central rod is located in front of the anterior capsule to create a capsular clip. A 3-piece IOL is inserted, in this case using forceps, but alternatively it can be injected into the bag in the regular fashion. The leading optic is inserted easily. However, in order to facilitate dialing of the trailing optic, a temporary suture is made and the IOL is positioned in the bag. The suture is now permanently closed to ensure a central and stable position of the IOL. The knot is buried in the sclera and no flap is therefore required. Some surgeons are reluctant to use Prolene suture because of biodegradation of this material and they fear that the suture may break after a few years. In my personal experience, this may occasionally occur with a 10-0 Prolene, but not with a 9-0. In this second case, the capsular anchor was sutured using Gore-Tex suture. The suture is retrieved at one point using a scleral trocar. A 25 gauge needle was inserted through the sclera and externalized through the main corneal incision. The Gore-Tex suture can be easily threaded through the lumen of the needle. Now the anchor is inserted and positioned behind the lens capsule in a manner similar to what was shown in the previous case, with the two lateral arms located behind the anterior capsule and the central rod positioned in front to create a capsular clip. A temporary suture is made in order to stabilize the lens and facilitate removal of the soft lens material by aspiration. Then, the suture is permanently closed and the knot is buried in the sclera with the IOL stable and well centered.